Bismillahirrahmanirrahim. My name is Mubashir Cheema. I'm a plastic surgeon working in the UK, and today I'll be speaking to you about implant-based breast reconstruction as to why it is done, when, how, and why sometimes not to do it. When the patient comes to you for reconstruction, they of course have an oncological history, may have had neoadjuvant treatment, and are either due or have had surgical excision. Immediate breast reconstruction is carried out at the time of mastectomy and delayed breast reconstruction several months to years later. The concept of delayed immediate reconstruction is relatively new and is to reconstruct within a few days or maybe weeks so that histology is known, and this can be performed when the knowledge of histology will affect the reconstructive options. Immediate breast reconstruction is best for early disease that is not likely to need radiotherapy. Implant-based reconstruction is used for complete defects of the breast and arguably for large partial defects. For most immediate reconstruction, your patient has had a skin-sparing mastectomy, that is, there is a skin envelope and you need to provide volume. And implants are a good way to provide volume, again, ideally when radiotherapy is not needed. In order to know which implant, the breast width is the most important measurement, which decides the range of volumes available for a given implant type. The goal is to choose an implant which provides symmetry with the opposite side in terms of volume and ideally for the shape as well. It is worth thinking that the symmetry is not static in time and that you will have to consider how it will change over time as well. There are a few other implant characteristics you need to think of before choosing an implant. The implant is usually silicone filled. I do not recommend saline fill as a choice for definitive implant. Of course, expanders are outside the scope of our current discussion. The next important decision is the shape, which may be round or anatomical. Anatomical implants, because of their teardrop shape, are slightly lighter for the same base dimension as the round implants, but require a more precise pocket placement. There is an often quoted concern about the anatomical implants rotating, but you have to appreciate that round implants being heavier for the same base dimension are at higher risk of bottoming out. So, the total complications for either anatomical or round implants are not vastly different. So, the rotation argument does not hold any water. The anatomical implants give you another consideration as well, which is the implant texture. Textured surfaces were created to attempt to reduce adverse capsular contracture, which is the most common reason for a reoperation after reconstructive or aesthetic breast surgery. Whether textured surfaces succeed in doing that depends on who you ask. In general, plastic surgeons in Europe and Australia favor the textured surfaces, and those in USA do not. There is a great big debate behind this from each one's point of view. This smooth versus textured surfaces argument has been quite polarizing even at best of times. But if you have been following the literature for the last 3-4 years, there have been references to concerns about BIA-ALCL, which is the breast implant associated acute large cell lymphoma, a rare condition associated with aggressively textured surfaces and confined to the implant capsule, although there have been a small number of cases with disseminated disease and a few deaths. The highest incidence found was around 1 in 4,000, with certain textured implants which were taken off market in 2019. There is no current recommendation by any organization or regulatory authority to remove the existing textured implants. In terms of indications, to be honest, given the choice for a patient, as a plastic surgeon, I would normally go for autologous option for reconstruction, and my personal preference is microsurgical based. But I appreciate the general surgical colleagues tend to favor implant-based reconstructions. Implant-based immediate reconstruction is quick, but suffers with all the issues of having a foreign body. It has no intrinsic blood supply, so if the mastectomy flaps are compromised, that is bad. Again, more likely with the higher weight of round implants. Implant-based reconstruction looks different than the opposite side, especially over time, and the reoperation rate with implant-based immediate breast reconstruction is between 45 to 50%, most commonly for capsular contracture. May I strongly recommend that if nothing else, please consider using a latissimus dorsi pedicle flap. If you position your patient in lateral decubitus, a latissimus dorsi skin and muscle flap can be raised at the same time as a mastectomy. If you are going into the axilla, you already have the space to swing the flap from the back into the mastectomy defect. Its blood supply is very consistent and very robust. If you can handle thyroid vessels, believe me, thoracodorsal is a piece of cake. It can give you 3 or 400 ml of volume easily, and the patient has something that looks, feels, and behaves like their own tissue, and saves them on the cost of the implant. And if there is an oncological issue, you can irradiate at any time. Now, some people think that, well, my patients are from a poor background, or this doesn't happen in Pakistan. I'll tell you something. If your patient has a mobile phone less than 5-year-old, there is no need to offer them 50-year-old option for a reconstruction. I'll go even further, that if you have a mobile phone less than 5-year-old, you have no justification to offer a 50-year-old operation to your patient as the standard and the only practice. Yes, there are times when implant-based reconstruction is a reasonable option, but that, in my opinion, should not be the standard practice and the only option offered to every patient. Now, if you are hell-bent upon using an implant, there is one option that can sometimes help to reduce the risk to mastectomy flaps and against capsular contracture, and that is using acellular dermal matrix. Choose a favorite one, and I will tell you now you have two problems. It is costly, it is fiddly, it takes time to learn, and increases time in your surgery. Don't get me wrong, people have had good results after using ADMs, but I always think of the blood supply. And in my point of view, after using that in immediate reconstruction, you basically have two dead things lying over the mastectomy skin flap, which itself needs to survive, but now has to accommodate the dermal matrix until it supposedly incorporates over the coming months, as well as the weight of the implants. Any infection in there and all your hard work is undone very quickly. One thing that I have seen work is not an ADM, but a Vicryl mesh. And this particular one comes under the brand name of Tiger Mesh. I have no association or commercial interest with the brand or its manufacturers. It is a wide mesh as opposed to the rather dense Prolene mesh used for hernia repairs. Being a very wide mesh, it still gives you good structural support and molds itself easily. And being sparse, it does not have a huge foreign body reaction. For delayed breast reconstruction using implants, I have similar concerns. Plus, now you need to provide a skin envelope as well as the volume. I suppose you can do 2 or 3 separate operations, put in an expander, fill it up over time, and finally change it to a definitive implant and make it look like an inverted bowl after several months. Or you can do a slightly longer operation in one go to give the result that looks, feels, and behaves naturally. This would again, at the very simplest, can be a pedicle latissimus dorsi flap, which gives you volume as well as skin, even if you are not a fan of microsurgery, which, by the way, I assure you is technically not that difficult. You can still use a pedicle latissimus dorsi flap. It can easily be raised in 60 to 90 minutes and saves you the cost of the implant. And for those who argue that implant versus autologous does not matter to their patients, and usually these are male surgeons who argue that, I tell them that look, this is an organ of femininity for that patient. What if your organ of masculinity had to be removed and you were given the option either to have it reconstructed with your own tissue or with an imitation made of plastic? That usually gets the point across. I thank you.